And finally, can you do the next slide? Sorry, Vinny.
Yeah, 1 sec.
Yeah, thanks. So these are just our partners. Just want to say thank you to MDU, More Than Skim Deep, Teach Me Surgery, Past MRCS, and Geeky Medics. And thank you to all of them for helping us make this possible. And without further ado, it's not for me talking. I will hand it over to Vinay.
Yeah. Thanks very much, Zach, for that introduction. That was very kind of you. And thanks very much, everybody, as well, for attending the session. So, Zach mentioned, I'm Vinay from Queens and Belfast. So, I'll be doing the PBL session for you guys. So, today's PBL session is mainly focused around intracranial hemorrhage, raised ICP, and hydrocephalus, and things like that. But we'll try to keep it as, to the point as possible. I don't want you guys to be hanging around for too long as well. I know you guys have stuff to do. I will ask questions now and then, maybe, if I'm thinking of anything, but, if you guys have anything else as well, put it down in the chat and we can see. So in terms of learning objectives, so we're thinking of, trying to differentiate extradural, subdural, and subarachnoid hemorrhage by history, pathophysiology, and CT appearance, describe the meningeal layers, key vascular anatomy, like the middle meningeal artery. So you'll come across of it as MMA sometimes in short, bridging veins, and the circle of Willis, very importantly. So the define, raised intracranial pressure, ICP, recognize its clinical progression and explain the Monroe-Kelly doctrine, something that you'll probably would have heard in your neurosurgery attachments and things like that. Explain the mechanisms and key signs of herniation. So whether it be uncal herniation, subthalassine, tonsillar herniation, there's also something called central herniation, but I'm not really going to talk about that. And then outline the etiology and emergency management of hydrocephalus and acute neurosurgical emergencies. Okay. So first case, we'll talk about somebody who had a head injury, because that's the most common thing that you'll see. So this is Mr. Patel, a 45-year-old man who slipped while fixing a light at home and struck the left side of his head. His wife reports that immediately after the fall, he had a brief loss of consciousness, but then regained consciousness within 1 to 2 minutes. After that, he complained of a severe worsening headache, and he has also had multiple episodes of nausea and vomiting. On arrival to the A&E, he's alert and oriented, and there's no external bleeding, no scalp herniation, laceration, and no neck stiffness. Now, at first glance, because he's awake and talking, it might be tempting to feel reassured. But this is exactly the kind of case where we need to be careful. So normal initial examination does not actually exclude an evolving intracranial hemorrhage. So at this stage, I want you guys to start thinking a bit more broadly. So what are the possible intracranial injuries after head trauma? You can think of that. What is the significance of that brief loss of consciousness, which we'll come into as well, and which features in this history make you worry that this could be a serious intracranial event rather than just a minor concussion. So before we reveal anything further, the key task here is to identify the red flags, think about the likely differentials, and decide what we need to do next and what we need to investigate urgently. So the questions you see in the box, if you guys can put something into the chat, that'd be great. It'll make the session a bit more interactive as well. So any immediate red flags, differentials, what you guys think, what to do next, what investigations as well. I know this is less information, but we'll get onto it further.
Michael is saying lucid period for EDH.
Very good. Fantastic, Michael. Brilliant. So I'll just go into the next slide. Thanks, Zach, for that. So initial A&E priorities. So let's think of that because it's very important. Some of you guys may want to be an ED doctor. So the first step is always an A2E assessment, while also considering C-spine precautions as well, especially, following the Canadian C-spine rules as well. If you're doing a CT non-contrast, especially the mechanisms or symptoms suggest possible C-spine injury. So if there's a severe neck pain, concerning mechanism or suspicion of cervical spine injury, the patient should be appropriately immobilized, of course, with blocks or things like that. So at the same time, we want frequent neurological observations. That means documenting the GCS, pupils, limb power, and then repeating these regularly, because in head injury, the trend over time is extremely important. It's important to track the patient over time. So at this point, he's alert and oriented. So that corresponds to a GCS of 15 out of 15, but that does not really rule out deterioration. So just to remind ourselves, the Glasgow Coma Scale looks at eye opening hearing, verbal response, and motor response. So to assess consciousness. So there's a picture there you can see to illustrate how you calculate GCS as well, and it's very important, especially when you come to your placements as well, anywhere, any ward, whatever you're in. So we also want to focus history. So we need to clarify the falls history, especially if you're seeing a geriatric patient or anyone who's old and, above the age of 65, maybe. No one's really old. Age is just a number. The biological age can, of course, be different, but you definitely want to look at the falls history in that case, relevant past medical history, and any diagnosis or medication that may increase risk. One especially important question is whether the patient is on antiplatelets or anticoagulants, because if they are, the threshold for concern is even higher. So if there is intracranial bleeding, especially on the CT, that needs urgent senior input and often neurosurgical discussion regarding whether reversal is needed, depending on the drug involved. So supportive management matters as well. So we should treat the pain, give antiemetics if needed, and most importantly, avoid any hypoxia, especially because it could cause brain injury, of course, and it's not really great. We know that, and hypotension as well, very importantly, because secondary brain injury can worsen outcomes significantly as well. So in terms of investigations, the key investigations you do is an urgent non-contrast CT head. Some of you guys would have guessed that. Even though his GCS is a 15, the history contains clear red flags: worsening headache, repeated vomiting, head trauma, and brief loss of consciousness. So he absolutely needs imaging. So a CT cervical spine, again, as I said, may also be required if the mechanism suggests possible C-spine injury. So you'd stabilize him in the ED with an Aspen collar, or using blocks and things like that. But I'm not going into that in detail. So just going into the next thing, I've just included a picture here showing the nice algorithm for deciding who needs a CT head scan after head injury in adults. So it's a very good thing. You guys can go through it, especially. So I think it's quite useful as well. The reason I've included this is to show that we did not order a CT purely based on whether the patient looks well at one single moment. We look for specific high-risk features that predict possible intracranial injury. So the major red flags include things like a GCS below 13 initially, a GCS below 15, 2 hours after injury, or a suspected skull fracture, or signs of a basal skull fracture. So you'd see things like raccoon eyes, and those are the things you'd see in the textbook. So a post-mastoidal scar or laceration. So things like that, and you could even see most likely a CSF leak. I haven't seen one so far, but again, a post-traumatic seizure as well is one more thing. Focal neurological deficits and more than one episode of vomiting. So these are the kind of major red flags that you'd be considering. Loss of consciousness or amnesia also becomes important when combined with additional risk factors. So in this patient, even though he initially appears alert, the combination of head trauma, brief loss of consciousness, worsening headache, and repeated vomiting that we were talking about is enough to justify an urgent non-contrast CT head. The important point here is that the clinical appearance alone can be misleading early on. As I said before, a patient may still have a GCS of 15 and yet have an evolving intracranial bleed. That's why these decision rules are really important. So the take-home message is quite simple. So in head injury, do not be falsely reassured by initially normal neurological examination when red flag symptoms are present. This patient clearly meets the criteria for urgent imaging, so that's why we do that. So in terms of our case evolving over the next 30 minutes in the emergency department, Mr. Patel becomes increasingly drowsy and confused. His GCS drops to 13, with eyes being about 3, verbal being 4, and motor being 6. And his wife says he's not making sense, he's not himself. So at this stage, we immediately repeat the ADE assessment and we perform another focused neurological examination. So reassessment is quite important. We always keep reassessing the patient. So now we find several very important new signs. His left pupil is dilated and sluggish to light, while the right pupil is normal. He also has weakness in the right arm and right leg, and his blood pressure is 160/90. This pattern is very concerning for an expanding left-sided intracranial lesion with rising intracranial pressure. So the clinical signs here show something called uncal herniation. So this is some term which some of you guys may know. For some of you guys who don't, it's where the medial temporal lobe, or the uncus, is being pushed downward over the edge of the tentorium. So tentorium is basically more of a flap that you'd see on top of the cerebellum. So it covers the cerebellum over the top and the bottom. Just to keep it in simple terminologies for now, you guys can search it online. Of course, it'll make more sense in terms of neuroanatomy. So due to due to raised intracranial pressure. There's sort of the pushing down of the uncus, compressing structures in the brainstem region. So the uncal herniation causes the clinical signs that we're seeing, regarding the pupil and the motor weakness and stuff I'm talking about. So the unilateral left dilated pupil suggests compression of the left oculomotor nerve, which is cranial nerve 3, as we know, which is a classical sign of uncal herniation itself. So here the medial temporal lobe is being pushed downward, compressing the ipsilateral oculomotor nerve, so on the same side. So where the uncus basically herniates, it's on the same side. It causes a lesion on top of the oculomotor nerve, giving a dilated pupil on the same side. It can also compress descending motor pathways called the corticospinal pathway, producing contralateral weakness and worsening consciousness. So it's also a good idea to possibly go and revise your pathways as well. So your neural pathways, it's quite important as well. So you can go and read that in your own time. The right-sided weakness now fits with the compression of the corticospinal pathways above the pyramidal decussation. So that's where the pathways cross. So the motor deficit is contralateral, so the opposite side to the lesion. So the corticospinal tract is the main motor pathway carrying movement signals from the brain to the limbs, because these fibers cross in the lower brainstem. Compression on the left side above that crossing produces weakness on the right side. Now, Matthew, if I'm getting the name right, fantastic. So this also introduces the concept of lucid interval, as you said. The patient briefly lost consciousness at the time of injury, then temporarily recovered, and then deteriorated as the bleed expanded and the mass effect, as we call it, increased. Now, mass effect is a very important terminology. You'd see it in a lot of CT scans as well. The radiologists love it, so you can go and read on that. But I'll cover it as well, and when the scans come in the later slides. So that sequence, this sequence we're talking about, is highly suggestive of an arterial extradural hemorrhage, because arterial bleeding can initially be compensated for, but then the decompensation can happen rapidly as intracranial pressure rises. So the key message here is that the patient is no longer someone with a head injury and a headache. He's now showing signs of raised ICP and impending brain herniation, which is a life-threatening neurosurgical emergency. So in terms of CT head findings, this is a non-contrast CT head, and the key finding you can see here is a left-sided biconvex, or lens-shaped, as it's called, hyperdense lesion. So you can see it's a bit more vibrant or bright, so you call it hyperdense. So hyperdense simply means it appears bright white on CT, which is what we expect with acute blood. So the shape is very important. This collection is biconvex, which is a type of an extradural or epidural hemorrhage. It has that appearance because the blood sits between the skull and the dura. So you have the different layers of the meninges, of course. If you guys, just to recap, so you have the skull at the top, and then you have the dura, the dura, the arachnoid, and the pia mater. So you can go and revise that as well, just as part of neuroanatomy. But it sits between the skull and the dura, so it's called extradural, just above the dura, and the dura is tightly adherent to the tissues, the sutures. Sorry. So by the sutures I mean the skull bones. So the collection does not usually cross these suture lines. So where we can also see the significant midline shift, here, meaning the mass effect, as I was talking about from the bleed, is pushing the brain across to the opposite side. So I know the CT is a bit hard to see there, but you can see the kind of midline that we talk about. Basically, the straight line that runs down the middle is slightly, pushing towards the right side. And that's just because of the brain bleed on the left side, as you can see. And that's what we call a midline shift. And, again, it's called a mass effect. So the mass basically here refers to the blood in simple terms. So here you can see the ventricles are being compressed. It's quite hard to see there, but possibly, if you zoom into the image, if possible, you can see that there's a bit of compression on the ventricle, the lateral ventricle on the left-hand side, especially because of the bleed, which is another sign that the intracranial pressure is rising. So clinically, this fits with already what we saw, worsening consciousness level, pupillary abnormality, contralateral weakness that I was talking about, and early signs of uncal herniation as well. There's also fracture in the pterion region on the left side. So the pterion basically is the thin region on the side of the skull. I've included a picture there below. You can see there, it's a region on the side of the skull where several skull bones meet. So mainly the frontal, parietal, temporal and the sphenoid bones. So it is clinically important as well because the middle meningeal artery, the MMA, as I talked about earlier in the learning outcomes, runs just deep to it. So a fracture here can tear that artery and cause an extradural hemorrhage. So the MMA is the classical arterial source of extradural hemorrhage. So less commonly, extradural bleeding can be venous as well sometimes. So, but in this case, the history of trauma and the brief lucid interval as well, what we talked about, and the Terrion fracture all strongly point towards the MMA artery injury. You may also be asked sometimes, why are the ventricles compressed? The answer is that the expanding hematoma, again, as I said, is occupying the space within the skull, increasing the ICP and distorting the normal brain structures. So that would be the answer. So instead of CSF pathways being enlarged as in hydrocephalus, here they are being squeezed by mass effect. So in terms of interpreting the scan, if you're going to tell it to someone, you'd say there's a left-sided extradural hemorrhage with significant mass effect, midline shift, and early uncal herniation. Although, of course, you wouldn't be able to say the uncal herniation just from the CT there, but just for information based on the case and clinical context. So going to the next slide. So in terms of severe raised ICP, the important thing is to talk about Cushing's triad here. So after the CT results, the neurosurgical team is contacted urgently, but the patient continues to deteriorate. He is now worsening GCS, abnormal flexion to pain on the right side, a heart rate of 49 beats per minute, irregular respirations, and a blood pressure 180 or 95. This is classic for severe raised intracranial pressure with Cushing's triad. Now, Cushing's triad, very importantly, consists of three things. So a triad, so hypertension, bradycardia, and irregular respirations. So high blood pressure, low heart rate, and irregular respirations. So, and it's a worrying sign because, it suggests that the brain is under critical pressure and herniation may be imminent or already occurring. So the underlying physiology relates to reduced cerebral perfusion. As intracranial pressure rises here, the cerebral perfusion pressure falls. So you call it the CPP. So when the ICP rises, something called the CPP falls down because the brain can only be perfused properly if mean arterial pressure remains greater than the intracranial pressure. So the arteries need to push the blood or flush the blood, against the cerebral, against the intracranial pressure pretty much. So if the ICP goes high, the CPP goes low. So the ICP continues to rise, the brain becomes relatively underperfused and hypoxic. So the body responds by increasing systemic blood pressure pretty much in an attempt to maintain cerebral perfusion. And that hypertension then triggers a baroreceptor reflex, which you guys would have studied in your early preclinical years, which then again leads to bradycardia pretty much. So that's the cause for the bradycardia there. So as the pressure worsens further, the brainstem becomes compromised, producing abnormal or irregular breathing. So that's the whole kind of pathophysiology in terms of why you get the triad in the first place. So I hope all of that makes sense there. Now, again, another important thing is the Monro-Kelly doctrine. This, again, links to that, the stuff I've talked right now, which tells us that the skull is a fixed space containing brain tissue, blood, and CSF. If one component expands significantly and the others can't compensate any longer, the intracranial pressure rises sharply. I've also included a diagram showing different types of brain herniation here. So due to this raised intracranial pressure, it forces the brain tissue to shift from one compartment to another, compressing the vital neural structures. In this case, the most relevant pattern, again, is the uncal herniation. Other types of brain herniation include subphallacean and tonsillar, which I was going to come at. So subphallacean herniation is when the brain tissue is pushed under the falx cerebri. So falx cerebri is pretty much the bit that separates the two cerebral hemispheres. So again, the subphallacean herniation may compress the anterior cerebral artery, which is quite important to know. So weakness can be more prominent in the leg, and in terms of tonsillar herniation, which is the other bit, is when the cerebellar tonsil, so the either bit or half of the cerebellum, to keep it in simple words, are forced downwards through the foramen magnum, which is the opening at the base of the skull. This is especially dangerous because it compresses the brainstem, which is actually passing through the foramen magnum, which can cause the respiratory failure we're talking about, and also cardiovascular instability and death. This also it helps explain abnormal posturing. So posturing suggests, severe dysfunction of the corticospinal tracts and our brainstem due to rising ICP and compression of the central motor pathways. So when a patient with a head injury develops, abnormal flexion or extension, we should be thinking of worsening mass effect, possible herniation, and impending neurological collapse. So the big message is that the herniation is not just an imaging finding. It produces recognizable bedside signs as well, such as a unilateral dilated pupil, contralateral weakness, reduced consciousness, and abnormal posturing. Without urgent decompression that you can do, this can rapidly progress to brainstem failure and death because of the pressure. On the brainstem. So what do we do next? This is now a neurosurgical emergency. We call neurosurgery urgently and prepare for definite decompression. So we optimize the airway. We call the anesthetist, of course, and if the patient's hypoxic, unable to protect the airway, or has a very low GCS, he may need intubation very much. And we elevate the head of the bed to about 30 degrees, keep the neck in the midline, and relieve any venous outflow obstruction, of course. For example, if the patient is in a cervical collar, like an Aspen collar, for example, this can be loosened as much as safety allows, of course, because you need to protect the C-spine as well to improve a bit of venous return, while still maintaining these C-spine precautions if needed. Also, if the patient's intubated, there's a concern about acute herniation. We can also then use like brief controlled hyperventilation as a temporizing measure. So lowering the PaCO2, the partial pressure of carbon dioxide, causes like cerebral vasoconstriction then, which reduces the cerebral blood volume and can transiently kind of reduce the ICP. It's kind of a temporary measure that can be used, but this is only a bridge to definitive treatment, not really a long-term solution, pretty much. We also maintain cerebral perfusion and, correct any reversible contributors. Now, medical treatment for raised ICP includes like hyperosmolar therapy, such as mannitol or hypertonic saline, which work by drawing water out of the brain tissue and reducing the cerebral edema. But in this case, the definite treatment is, of course, urgent craniotomy. So you get a neurosurgical team involved for evacuation of the extradural hemorrhage. Burr is not the definitive answer here. The clot is not something that can be reliably be dealt with by burrs because the blood will be quite viscous as well. So, it's said that can't be evacuated out of by the burr holes, and the patient needs proper surgical evacuation as well, again, and hemostasis through a craniotomy, pretty much. So, and so the key point is this, patient needs to urgently go to theater, pretty much. You don't really wait here. In terms of anatomy and the bleeding spaces, so this is what I was going to come at. Now that you have the meninges, which are the protective membranous coverings, surrounding the brain and the spinal cord, and there are three layers: the dura mater, the arachnoid mater, and the pia mater. So these layers do two important things. First, they provide a supportive framework for the cerebral vasculature. Second, together with the cerebrospinal fluid, they help cushion the central nervous system as well and protected from mechanical injury. So quite very supportive and good for us. Understanding the meningeal layers helps us understand the different bleeding spaces in head trauma. So an extradural hemorrhage lies between the skull and the dura, as I said earlier. It is classically associated with trauma to the MMA, the middle meningeal artery, and which is sitting just near the pterion, as we talked about earlier as well, just to recap, and typically appears biconvex again, if you remember the CT there. And a subdural hemorrhage lies between the dura and the arachnoid. So it's subdural, just below the dura. So if you just kind of break the word, you'll be able to understand it easily. And it's usually due to tearing of the bridging veins there. A subarachnoid hemorrhage, or lies in the subarachnoid space, so just below the arachnoid membrane. So where CSF circulates around the sulci and the cisterns. So cisterns in the sense the basal cisterns. That's what we'd be talking about, and I'll come into that a bit. So this case is a classic example of extradural hemorrhage again. But the wider lesson is that when we assess head trauma, we need to think anatomically about which compartment is bleeding. That's why I have the slide here. So because the source, the CT appearance, and clinical course and management can all differ depending on the space involved. So let's go into case 2. Great, we've done 1 out of 4. This is Mr. Jackson, a 76-year-old man who's been brought in by his daughter with progressive confusion and headache. Straight away, this feels quite different from the first case because this is not really a sudden dramatic deterioration after a recent injury. This sounds more gradual and more insidious. Looking at the history, he had a fall 3 weeks ago. hit his head on a door frame. At that time, he went to the emergency department, had a CT head. It was reported as normal, and he was discharged. Since then, though, he has had a dull headache that has gradually become worse over time. He has no vomiting, no meningism. So meningism pretty much refers to the signs and symptoms that mimic meningitis. So could be things like neck stiffness, could be things like headache, fever, photophobia, etc., without actual inflammation or infection of the meninges. So no obvious signs suggesting meningeal irritation here. His past medical history is very important. He has a metallic heart valve, and he's taking warfarin. This matters a lot because warfarin is an anticoagulant, so it increases the risk of bleeding and also increases the risk that a bleed, once it starts, will expand inevitably. On examination, his GCS is 14, so he's mildly confused. His pupils are equal and reactive. His observations show a blood pressure of 150/85 and a heart rate of 88. So how do we manage this patient initially? Any comments, put it down in the chat. It would be great if you guys interact as well. So as always, we begin with what NADE assessment in the ED. So we get the ED docs first. So seeing the patient and a focused neurological examination. We also want baseline bloods, including an FBC or a full blood count, urea and electrolytes, UNEs, CRP, C-reactive protein, LFTs, liver function tests, and the INR, international normalized ratio. I think that it's called. The INR is basically important because it tells us how anticoagulated he's on warfarin. So the fact that he's on warfarin should be flagged early to your senior, and if the CT shows blood, this needs urgent discussion with neurosurgery in general. Now, if there's an intracranial bleed, pretty much the neurosurgical advice would usually be to stop the warfarin, reverse it, of course, and often withhold it for around like 2 weeks. But in this patient, that decision is more complex because he has a mechanical heart valve, so kind of complicates things there. So stopping anticoagulation carries a risk of valve thrombosis or embolic complications. So in practice, if there is a bleed, the emergency department team would need to involve both neurosurgery and cardiology as well here and make careful risk-benefit decisions. So now, if urgent reversal is needed, one option is PCC, or known as prothrombin complex concentrate. So an example in the NHS sometimes used is Octaplex. I've seen in Northern Ireland. So PCC gives rapid replacement of clotting factors, which is why it's used in emergency reversal. So vitamin K can also be used, of course, but it works more slowly. You would have read that possibly in stuff like PassMed or whatever. But so in an acute situation, PCC is more important. The exact dose and infusion rate depend on the protocol and are often weight-based. So you would always check local guidelines as well, so your trust guidelines. So in terms of general management, we'll also give analgesia, antiemetics, very important if needed, and make sure we avoid hypoxia, hypotension, because both can worsen secondary brain injury. Again, same just like the first case. And the key investigations here is, again, urgent non-contrast CT head. Even though his original CT was like 3 weeks ago was normal, he's now worsening, so we do it again. He's elderly as well, he's confused, he's anticoagulated, so we absolutely need to scan him again. So we do. To go to the next slide, so here CT head findings. So non-contrast CT head, so it shows a left-sided. If you see it on the left side, it's a crescent shaped. It's like the shape of a waxing moon a bit, or banana shaped. Sometimes it's called that. It's a hypodense lesion in this case. So there's a kind of a reason for that, but which I'll go into later on. But hypodense means it looks darker than the surrounding brain on CT. The overall interpretation is that it's a chronic subdural hemorrhage. Sometimes it's called a CSDH in short. Subdural hemorrhage is a collection of blood between the dura mater and the arachnoid mater. On imaging, it typically looks a crescent shape because it can spread out along the surface of the brain. Unlike an extradural hemorrhage, it's not really tightly limited by sutures, which is why you can see it kind of spreading over the surface of the brain. So it gives that kind of shape of a waxing moon, as I said. Because an extradural, as we talked about earlier, is limited by the suture lines. Where the place where the dura basically sticks onto the skull. Because as the skull basically is just bones just coming together, and those are the suture lines as we talk about. The density also helps us judge the age of the bleed. So an acute subdural hemorrhage, usually within the first few days, tends to be hyperdense, so it looks very bright. So that's an acute scenario, but a chronic one, usually after about 3 weeks, like about 21 days ish, becomes a bit hypodense. So it looks a bit darker. That fits very nicely with the patient's story of a fall 3 weeks ago, followed by gradual worsening of symptoms. Even though this is a slower bleed than an extradural hemorrhage, it can still become dangerous. Like an extradural, a subdural can cause raised ICP as well, compression of the ventricles. Now, in this image, it's a bit more clear. You can see the ventricle on one side, the lateral ventricles, again, shaped like a banana, but on the left side, you can't really see it. It's kind of just closed down pretty much. It's compressed, and you can also see a bit of midline shift as well. So midline shift is pretty much, again, the line that runs in between the brain, separating the both hemispheres, and you can see it's a bit more deviated towards the right side of the brain. So and potentially herniation as well, if the mass effect could be there if it becomes severe enough. Now, again, the mass is the blood. The herniation pattern classically associated here is subphallacean herniation. In the previous case, I explained the different types of brain herniation. So to recap, subphallacean is when the brain tissue is pushed under the falx cerebri, which is the midline fold, again, of dura between the two cerebral hemispheres. So just make that clear. So that's the falx cerebri that we talk about. So when that gets pushed, that's basically the midline that you're actually seeing on the image anyway. So one important consequence is that it can compress the anterior cerebral artery, and that may produce weakness again, especially left leg weakness, as we talked about. The key point is that the CT appearance, the time course, and the symptoms all fit together really well. And this is a left-sided, so chronic subdural hemorrhage. Anyway, so going to the next one. So let's talk about subdural hematoma, which is generally the usual cause is venous bleeding from ruptured bridging veins. These bridging veins drain deoxygenated blood from the surface of the cerebral cortex, pass through the subdural space, and empty into the dural venous sinuses. So they drain through the sinuses, especially the superior sagittal sinus, which is just kind of quite close to the falx cerebri, when you look at images anyway, because they are stretched across that space. They're vulnerable to tearing when the head moves suddenly, or after trauma. There are really two broad patterns you need to know. The first is basically a high injury kind of mechanism, such as a road traffic collision like an RTC, falls from a height, or high impact sports injuries. Those are more kind of common, of course, in younger people, as you can imagine, and can cause an acute STH, often along with a significant primary brain injury sometimes as well, you may see. So in children or babies, you would also think about non-accidental injury, or NAI, you would see in the notes sometimes, in medical notes. The story does not fit. The second is a low energy mechanism, such as a simple fall or even like a jolting movement, and that is particularly common in older people. And these can lead to either acute or chronic subdural hematomas, depending on how much bleeding occurs and how quickly it accumulates. One of the key teaching points is that subdural hematomas usually present more slowly than extradural hemorrhages. The reason is that the bleeding is usually venous, so it is under lower pressure, as you can imagine, and accumulates more gradually. This often happens in older patients of some degree of kind of cerebral atrophy, especially people who have like Alzheimer's and dementia and things like that. So meaning the brain has shrunk slightly with age. That creates extra space inside the skull, so blood can accumulate for a while before it causes obvious focal signs, neurological signs or mass effect. That's also why the initial CT in the ED 3 weeks ago may have been normal. And in terms of clinical features, the presentation can be quite subtle at first. Patients, could have a headache, confusion again, drowsiness, reduced GCS, fluctuating consciousness. They can also develop focal neurological deficits, for example, like weakness or aphasia, meaning difficulty with speech pretty much, or slurred speech. Some patients present mainly with personality or behavioral change, such as becoming unusually aggressive or having rapid mood swings. So the important risk factors to remember are older age, because age-related brain atrophy stretches the bridging vein. So that's pretty much what's being thought. Alcohol dependence, because that can also cause cerebral atrophy, even in younger people, and increases the risk of falls. Anticoagulants, antiplatelets, because they increase the bleeding risk, of course, and the chance of expansion, and also seizures, recurrent falls, coagulopathy, such as liver disease and previous subdural hemorrhage. That's why it's also sometimes oftentimes important after you solve these problems to consider maybe an orthogeriatric assessment, if they're especially, considered under geriatrics pretty much. Now management depends on how big the bleed is and how symptomatic the patient is. So some patients can be managed conservatively, especially if the bleed is small and they have minimal or no symptoms. In that situation, the body may gradually reabsorb the blood over several weeks. So management can be more of a watch and wait approach with monitoring and reversal of antithrombotics after specialist input. Seizure prevention may also be considered in selected patients. And in a patient on warfarin, again, we talked about reversals, so I'm not going to go into that, but that will be done. We also need to think about, again, that's PCC plus vitamin K. And we also need to think about, whether it's a good candidate for surgery because, he's older and frail patients, with multiple comorbidities. The risks of surgery may in some cases outweigh the benefits. But surgery is needed when the bleed is larger or more symptomatic, of course. As a general rule, surgery is considered if the hematoma is more than 10 millimeters thick, if there's a midline shift, or if the patient has fluctuating reduced consciousness, confusion, or reduced GCS, or maybe even a focal neurological deficit, maybe. So in this particular case, because our patient is actually symptomatic, is showing symptoms and confused, he would need a surgical assessment. So the type of surgery depends on the nature of collection. So burr holes are usually used for fairly homogeneous chronic subdural hematomas without significant membrane formation. A mini craniotomy sometimes may be needed when there are significant membranes or a more complex organized collection. In more acute traumatic settings, especially when there's raised intracranial pressure, IV mannitol can also be used, although that is more relevant in the acute trauma phase rather than routine conservative management of a stable chronic subdural. So the overall message is that a subdural hematoma is often a slower, more insidious intracranial bleed, especially in elderly anticoagulated patients. And that is exactly why it is so important not to be falsely reassured by a normal scan or mild symptoms earlier on. So in terms of case 3, we've come to the third one. So this is Mrs. White, a 52-year-old woman who collapses while exercising and then describes a severe headache as the worst headache of my life. That phrase should immediately make us think of a thunderclap headache, a good one for the MCQs, of course. Thunderclap headache is a sudden severe headache that reaches maximal intensity very quickly, often within seconds, and classically within minutes at most. That is a major red flag for subarachnoid hemorrhage. Looking at the history, she's had a brief loss of consciousness at onset lasting seconds to minutes. After that, the headache came on suddenly and reached maximal intensity in seconds. She also has vomiting, photophobia, and neck stiffness. So photophobia means light sensitivity, and along with neck stiffness, these are meningism symptoms, meaning that features that suggest irritation of the meninges by blood in the subarachnoid space. Her past medical history is unremarkable. So her GCS is 15, so she's fully conscious. She's clearly distressed. Blood pressure 175 or 95. Elevated blood pressure fits within a possible acute intracranial event. So the initial management here is very similar in the structure to other cases, but the differential is kind of different. We start again with an A to E assessment, the same thing, do a focused neurological examination, send bloods, FBC, UNE, CRP, LFTs. We give analgesia antiemetics again, and we avoid hypoxia and hypotension because those can worsen secondary brain injury. The key investigation here is an urgent non-contrast CT head again due to red flag symptoms. So it's the same thing again and again. Sudden collapse, thunderclap, headache, vomiting, photophobia, neck stiffness, all of these are red flags. Even if the patient looks relatively stable at the moment, this presentation should be treated as a neurosurgical emergency until proven otherwise. And in terms of CT head findings, on a non-contrast CT head, we can see the classic appearance of a subarachnoid hemorrhage. This includes hyperdensity, meaning bright white blood within the basal cisterns. So you can see an arrow there, pointing to the basal cisterns right there. It's not really perfect there, but you can kind of see, there's another image. Yeah, there's another image on the right-hand side where you can see kind of the basal cisterns marked and the Sylvian fissures as well. So these are kind of important things that you could know, especially in radiology imaging, sometimes be mentioned. So you see bright white blood within the basal cisterns, the Sylvian fissures, and cerebral sulci. Sometimes this creates what people call a star sign or star pattern around the circle of Willis. So you can see kind of a star kind of a pattern there. So in more severe cases, blood can also track into the ventricular system. So the interpretation here is subarachnoid hemorrhage. An important diagnostic point here is what to do if the CT is normal. If the CT is done within 6 hours, very importantly, of symptom onset and is reported and documented by a radiologist as showing no subarachnoid hemorrhage, then under current NICE guidance, you don't actually offer or routinely do a lumbar puncture. In that situation, the hemorrhage is unlikely, and you should think about alternative diagnosis and discuss with a senior specialist or a consultant. That said, the history still matters very hugely, and if clinical suspicion remains extremely high, you would still seek specialist advice and may need to do an LP if the clinical suspicion is present for an SAH. If the CT is done more than 6 hours now after symptom onset and is normal, then diagnostic accuracy falls because the blood becomes harder to detect on CT as it becomes more diluted and redistributed within the CSF. In that situation, you should consider lumbar puncture, and it should be done at least 12 hours after symptom onset, as you can see on the slide, to allow bilirubin or xanthochromia to develop. And NICE recommends diagnosing the hemorrhage on LP when there's elevated bilirubin, and spectrophotometry, which is done as well. It is worth explaining xanthochromia because it comes up a lot in exams sometimes. So xanthochromia is the yellow discoloration of the CSF, cerebrospinal fluid, caused by the breakdown of red blood cells. The hemoglobin released from the red cells is metabolized over time, eventually producing bilirubin. So hemoglobin becomes oxyhemoglobin plus bilirubin. So that's the transformation pretty much. And the bilirubin gives it the characteristic kind of color, and spectrophotometry is used to detect bilirubin and oxyhemoglobin. This is useful because it helps distinguish a true subarachnoid from a traumatic tap, where blood is introduced by the lumbar puncture itself. So a traumatic tap gives you fresh blood, whereas xanthochromia suggests that blood has been sitting in the CSF itself for hours and has broken down. Once a spontaneous subarachnoid is confirmed, the next step is to identify the source of bleeding. The first vascular test recommended is CT angiography of the head, done without delay, to look for an aneurysm and guide treatment. So in terms of, let's talk about subarachnoid hemorrhage more generally. In terms of etiology, subarachnoid can be traumatic or spontaneous. Subarachnoid is the most common overall cause, but when we talk about the classic thunderclap headache emergency, we're usually worried about a spontaneous subarachnoid, most commonly from rupture of an intracranial aneurysm. The classic aneurysm here is a berry-aneurysm, also called a saccular aneurysm. So saccular means it's rounded, outpouching like a sac from one side of the artery wall, in contrast to a fusiform aneurysm where the vessel dilates more circumferentially, around the segment. So these aneurysms often arise at arterial branch points in the circle of Willis, and that's an important point to know because these sites are exposed to hemodynamic stress. Important risk factors of berry-aneurysms are things like polycystic kidney disease, which is a good exam question, Ehlers-Danlos syndrome, coarctation of the aorta, hypertension, smoking, family history, and all those cardiovascular kind of risk factors. These are all, and family history is also really important as well. So it's a good one to note. These all either reflect vessel wall weakness, increased hemodynamic stress, or both. Clinically, the hallmark feature is the thunderclap headache that patients talk about. A sudden, severe, and maximal, like very quickly, rapidly progressing. Other features include nausea, vomiting, meningism, such as the photophobia and the neck stiffness that they may talk about, and normal or reduced GCS, seizures, and in some cases coma as well. So one eponym that can come up is Kernick sign. So that means the patient is lying supine with their hip and knee flexed to 90 degrees on the bed, and when you try to extend the knee, it causes a bit of pain or resistance because the meninges are kind of irritated. So management is time critical because a ruptured aneurysm is at risk of rebleeding. And once it is bled, it needs to be secured urgently, ideally within 24 hours. After a subarachnoid hemorrhage is diagnosed, the cause is identified with CT angiography again. And if an aneurysm is found, treatment is usually endovascular coiling. Nowadays, it's changed recently, in terms of technique performed by interventional neuroradiology, actually. A smaller proportion of patients need surgical clipping. Again, that's done by neurosurgery, of course, by craniotomy. So you open up the skull and you go in. So if a CT angiogram does not show the cause, and aneurysm is still suspected, so then you do a DSA. DSA is basically a digital subtraction angiography. It may be needed sometimes because it gives a bit more detailed vascular imaging then. Additionally, one aneurysmal subarachnoid is suspected or confirmed and the aneurysm is still unsecured. Blood pressure is usually controlled carefully to reduce rebleeding risk, commonly with practical target of the systolic blood pressure below about 160, while strictly avoiding hypotension. So other important aspects of management, we stop or reverse the antithrombotics where relevant, and the aim is to maintain euvolemia, of course, meaning normal circulating volume, rather than letting the patient become dry or overfilled. So the aim is generally around 3 liters of fluid per day post-surgery. The specific fluid targets can differ by local protocols, so always check this, but the key principle here is adequate hydration without hypervolemia. Another very important aspect of management that I can think about is nimodipine prophylaxis, because nimodipine, a CCB, calcium channel blocker, reduces the risk of delayed cerebral ischemia after aneurysmal subarachnoid hemorrhage. It is given early, usually enterally, so through the mouth, and so basically after a subarachnoid, there's a major risk of vasospasm. Importantly, so vasospasm is where there's a narrowing of the cerebral arteries, usually triggered by blood breakdown products in the subarachnoid space. This can lead to delayed cerebral ischemia, or DCI as it's called, meaning a new neurological deficit or new brain ischemia after subarachnoid that is not better explained by another cause such as rebleeding, hydrocephalus, or seizures. So nimodipine helps reduce that risk. If a patient develops symptomatic delayed cerebral ischemia, management may be including maintaining euvolemia, as I said, and in select cases blood pressure augmentation with vasopressors under specialist care, but nimodipine itself is not really the vasopressor. And other major complications of subarachnoid that are important to remember include rebleeding, hydrocephalus, and hyponatremia. First, so rebleeding can happen, as I mentioned earlier, and carries high mortality. If the patient suddenly deteriorates again, you should think about a rebleed and arrange a repeat CT urgently. NICE notes as well that the risk of rebleeding is the highest within the first 24 hours. Another complication that we can talk about is hydrocephalus, so where CSF drainage is blocked and the ventricular enlargement occurs, which is a classic thing. And acutely, this can be treated with an EVD, or an external ventricular drain, which diverts the CSF into a collection system at the bedside. Some of you guys would have seen it in the wards. Some patients later need a VP shunt or a ventriculoperitoneal shunt for longer term diversion, where you divert it into the peritoneal cavity, the CSF. Thirdly, hyponatremia can be a complication, which is often due to SIADH, symptom of inappropriate antidiuretic hormone, after the hemorrhage itself. So I appreciate there's only 10 minutes. We'll try and crack on. So the circle of Willis is an arterial ring at the base of the brain. So it forms an anastomotic connection between the major vessels supplying the brain, broadly speaking, the internal carotid circulation anteriorly and the vertebrobasilar circulation posteriorly. So its job is to provide some degree of collateral flow. So if one vessel is narrowed or blocked, other parts of the circle may help maintain perfusion, and it's good to remember this. The main named vessels to remember here are the anterior cerebral arteries, linked by the anterior communicating artery, the internal carotids, which continue into the middle cerebral arteries, and the posterior cerebral arteries as well, which connect to the internal carotid circulation via the posterior communicating arteries. So yes, basically it's a useful exam point that the internal carotid artery gives rise to the middle cerebral artery. You guys can of course go through it in your own time. Good videos to watch online as well. Common aneurysm sites to remember on the circle of Willis include the anterior communicating artery, the posterior communicating artery, so the ACA, the PCA as it's called, and the middle cerebral artery bifurcation, and the basilar tip as well. So these are the branch point locations, so which is why they're always prone to aneurysm formation in general. So most aneurysms are actually asymptomatic until they're either found incidentally on imaging or rupture and present as subarachnoid, but if they get large enough, they can cause focal neurological symptoms by compressing nearby structures. A classic example is a posterior communicating artery aneurysm causing a painful third nerve palsy. The oculomotor nerve, or cranial nerve 3, runs close to the posterior communicating artery, important point to remember. So an aneurysm here can compress that. So this gives the classic triad of ptosis, a dilated pupil, and the eye sitting down and out. Again, sometimes passed in exams. Ptosis happens because the levator palpebrae muscle is affected, your eyelid muscle, and the pupil dilates because the parasympathetic sympathetic fibers traveling with the third cranial nerve are compressed, and the eye deviates down and out because the muscles still functioning are mainly the lateral rectus and the superior oblique. I remember it by just thinking LR6SO4. So LR is lateral rectus, so cranial nerve 6, is giving that the innervation, and SO4 superior oblique. So if you see a painful cranial nerve 3 pulse, you should always think about a posterior communicating artery aneurysm, pretty much. Case 4, finally in our last case. So this is Miss Beth, a 24-year-old woman who presents to the emergency department with sudden severe headache, vomiting, and blurred vision, and a brief collapse in the bathroom. What makes this case interesting is that although today sounds acute, the history actually suggests this has been building for some time. She has had 3 months of intermittent positional early morning headaches with nausea, along with brief episodes of blurred vision over the same period. So the headaches are worse when lying flat and worse when she wakes up. And today she's had the worst headache so far. So that pattern should make us think about raised ICP. Headaches from hydrocephalus or raised ICP are often worse in the morning because CSF drains less well when lying flat overnight, so pressure can build up. Sitting upright may improve symptoms, at least early on. Blurred vision also fits because raised ICP can affect the optic nerves again and the eye movements. So there's no fever and no neck stiffness, so infection or meningitis is less likely from the story we have so far. Her GCS is 13, so she's no longer fully alert. Her pupils are equal and reactive, and fundoscopy. So sometimes you may see in medical notes PEARL, so I was confused initially what that meant. It just means pupils are equal and reactive to light. So you may see that in medical notes, PEARL, so P and RL. And fundoscopy shows papilledema. So papilledema means swelling of the optic disc due to raised intracranial pressure. You can see it on fundoscopy, and it is a very important sign here. Or if you use a slit lamp, maybe even. Her blood pressure is 170/95, heart rate is 52, which also makes you think about raised ICP. Initial management, ADV assessment, again, a focused neurological examination. So we do the same thing all the time, pretty much in the ED, and baseline bloods, including FBC, U's and E's, CRP, LFTs. We give analgesia, antiemetics as needed, and we avoid hypoxia and hypotension again, because those can worsen the secondary brain injury. And I'm repeating that just so that, you guys know what's done initially. The key investigations, again, urgent non-contrast CT head, no need to explain that further. So we need to do an urgent imaging anyway before we do anything more invasive. So in terms of CT head findings there, so if you see, it's a non-contrast CT head, shows marked dilatation of both lateral ventricles, while the fourth ventricle is normal or small. The lateral ventricles look a bit like Mickey Mouse ears, and it's a classic sign of gross ventriculomegaly. So the ventricles become big, the lateral ventricles. It's also good if you guys go and see the kind of diagram, in terms of ventricles, in terms of there's a sagittal section, if you see, below, and there's also one that there's also a different type of diagram I think you can find online, which shows it a bit different, like in a coronal section kind of. Anyway, but there's also a small rounded lesion at the foramen Monro, if you see. So I've marked that there in the green arrow. So there's a periventricular low attenuation, which represents transepidermal CSF flow. So that just means around the ventricles, low attenuation. So which means it's not really bright. It shows that the CSF is leaking outside. Pretty much that's why it's called transependymal. So ependymal refers to the cells that are secreting the CSF inside the ventricles. Also referred sometimes as transependymal edema. So what does that mean? So the foramen Monro is the channel that connects each lateral ventricle to the third ventricle. So if a lesion like a colloid cyst maybe blocks this outlet, CSF can't flow really normally out of the lateral ventricles. Pressure then builds up upstream, so the lateral ventricles enlarge. That is why the appearance is most consistent with acute obstructive or non-communicating hydrocephalus due to a colloid cyst at the foramen Monro with raised ICP. Now I'll come into what communicating and non-communicating mean anyway, but it's basically what it says on the tin. It just means means what it means, but I'll come into it after. Colloid cysts in this location are a classic cause of intermittent or acute obstructive hydrocephalus. The transepidermal flow is also important. The gray low density halo means CSF is, again, as I said, being forced under pressure into the brain tissue. So this actually shows the ventricle is stretching out and the blood-brain barrier is broken, and the fluid is being forced out into the surrounding brain in the cortex. In other words, it is a radiological sign that interventricular pressure is high. So next, basically going over the CSF pathway, just briefly in this context, it's produced by the choroid plexus. So by the cells, as I talked about, the ependymal cells. So it flows from the lateral ventricles through the foramina mundo into the third ventricle, and then it goes down the cerebral aqueduct. It's called, also otherwise called as the aqueduct of Sylvius, into the fourth ventricle. From there, it exits through the foramina magendie in the midline and foramina lusca laterally. So magendie is medial and lusca is lateral. So L for L and M for M. So you can think in that way. Enters the subarachnoid space around the brain and spinal cord, and then gets absorbed by the arachnoid villi or granulations into the dural venous sinuses. So it goes into the arachnoid space after drainage. It gets absorbed from the by the villi. There's also a smaller amount of absorption around nerve roots. Not really significant, but CSF movement is pressure dependent, so increased venous pressure can reduce absorption and worsen the hydrocephalus. So one useful pitfall to mention is that ventricles can be misleading. Bigger ventricles do not always mean acute hydrocephalus because they simply may reflect age-related atrophy. On the other hand, a patient can still have raised ICP with normal or small ventricles. For example, in idiopathic intracranial hypertension is a good example. And in patients who already have shunts, the ventricles may remain small even if the shunt fails, so the symptoms still matter more than a single imaging impression. So the take-home message from this slide is enlarged lateral and third ventricles, a normal or small fourth ventricle, a lesion at the foramina mundo, and transepidermal flow together point to the obstructive hydrocephalus due to a colloid cyst. So hydrocephalus here, just in general, it means an abnormal increase in the CSF volume within the ventricular system, causing active ventricular enlargement because CSF is not passing or being absorbed normally. If untreated, it can lead to neurological deficits, cognitive problems, visual problems, and in severe cases can be fatal. So this links very nicely to the Monro-Kelly doctrine I was talking about earlier. So that just means the skull is the Monro-Kelly doctrine pretty much says, because I didn't go very detailed into that earlier, the skull is basically a fixed rigid box containing brain tissue, blood, and CSF. If one of these increases, for example, because of a tumor or a bleed or excess CSF, the others initially have to decrease to compensate, often by displacing CSF first, but that compensation only works up to a point. Once the reserve is exhausted, intracranial pressure rises, and that's when patients develop headaches, vomiting, and reduced consciousness. I know it's 8 o'clock, so I'll just speak the last few points. So we have non-communicating and communicating, as it says on the slide. Obstructive is where there's an obstruction blocking the ventricular pathways. CT shows enlarged ventricles upstream from obstruction. Non-obstructive is communicating, so the ventricles are communicating normally, but CSF fails to be absorbed or overproduced. So I hope the slides will be shared so you guys would be able to then go through it yourself. And this is just the last, part of the last two slides pretty much. So the CD brain, again, uncommon signs. Common signs sometimes, you need to think about is a normal pressure hydrocephalus, which can be a chronic thing, and management, again, you do an A2E assessment, put an EVD in, and definite thing would be to remove the cause, if it's an obstruction, and, have a VP shunt in, or an ETV, an endoscopic third ventriculostomy, where you poke into the third ventricle space, and you do that. So you want to avoid an LP in obstructive hydrocephalus just because, removing CSF from below can create a craniospatial, pressure gradient, as is talked about, and can kind of cause brain herniation. So in summary, we went over 4 cases. We talked about the different types of hemorrhages, so subdural, epidural, subarachnoid. We talked about the management. We talked about hydrocephalus as well. So I hope all of this was useful. And pretty much these are kind of some of the references that I've used for this. So I've tried to make sure it's as accurate as possible. And I have to definitely extend a huge thanks to SUPTA, the team, Zach, of course, for co-hosting this, and Wing Joe as well, and my supervisor as well, the patron for SUPTA. So it's been a great time. Thanks very much, everybody, and I hope everyone enjoys the lectures.
Woo! Good job, Vinay. That was amazing. Thank you for that PBL session. So the feedback form, Joe, I believe, is going to send it into the chat so that everybody can fill that out. But yes, another massive thank you to Vinay for that session. I'm sure everybody found that very useful. The next session that we're going to have next week, we're going to do an upper limb trauma and orthopedics, and it will be on the Tuesday and Thursday. And you can look on our social media, and we'll send you updates. But yeah, if there's any questions, I'll just send our socials into the chat. But yeah, thank you very much, everybody.
Yeah. Thanks a lot, Vinny. Really appreciate it. Also, thanks a lot, Zach, for hosting this session. So I'm just sharing my screen. Are you guys able to see my screen now?
Yes, we can see your screen.
Oh, okay. Yeah. So to everyone who all attendees, so we are no longer using Google Forms for respond collecting responses. So now we are using QR codes, which are built-in functions like on the career book website itself. So once you scan this QR code, it should bring you to a page where after you sign in, then there's the feedback page there, where we really appreciate if you guys can fill it out, as that would mean a lot to Vinay, and also to let us know how we can improve in our future sessions. And once you have filled that up, a certificate will automatically be generated for you after that.
Amazing. Thank you, Joe.
Mm. So I'll keep this up for a few about a minute. In the meantime, if anyone has any questions at all, can don't hesitate to ask now.
People are saying the QR code isn't working, Joe.
Isn't working. Okay.
I'll try.
I'm not sure is it working for others. QR code isn't working. Yeah, I think it's a bit on and off because may I ask, have you, if it's not working, what may I ask what is the error showing? Is it showing that
Uh, I
that
can. It's working on my one. I don't know why it's working on mine.
yeah, because I think so far they have noticed is that if you have not booked the session before this, then probably it will come out, your screen probably will show error, report not booking. So may I ask, is that what is showing on the screen for you guys, or
Oh yeah, mine's saying that as well when I'm doing it. It'll be the same thing.
yeah, because so far only the feedback is available for like oh yes, this is no booking. Yeah, because it requires booking for like the um book.
Open G email. Okay.
Yeah. Okay. Never mind. What I'll do is I'll send a backup Google feedback form now. Just give me a few minutes. Sorry. Yeah. In the meantime, anyone who is able to scan the QR code, please use that method as well.
And what did you say, Joe? You're currently making a feedback form, or what's going on? Sorry.
Yeah, sorry. I'm sending a Google feedback form into the chat. This is for
Okay.
like anyone who is unable to access the QR code one.
Cool.
Yeah.
But yes, we have another session next week on trauma orthopedics. It'll be the same for the next 2 weeks, and all our stuff's on our website. So if you ever miss any of our sessions, please just go on our website. All of it is there. But yeah, thanks to everybody, and another massive thank you to Vinay for his session today. Cool. Is that form working for people? I'll test it to make sure it works for me as well. Yep, the form is working. Cool. Okay. Are we okay to end it there, Joe?
Yeah, I think does anyone has any last minute questions or anything? Going once, going twice. Okay. Anyways, if anyone has any questions at all, so do we
Alana, just try the Google form, and then that will give you a certificate for the Google form. Just copy and paste that link. I can copy and paste the link only. That might be more useful. But just use that link, and that should help you. But if you have any questions afterwards, for whatever reason, here's that email. You're gonna send us an email there, and I'll make sure that your stuff gets answered. Cool. Okay. Amazing. Nice. Have a nice evening, everybody. Thank you, Vinay, and we'll hopefully see you guys next week for the trauma orthopedics. Bye.